So can we start, sir?
Yeah.
Good evening, sir. I welcome to all of you on the behalf of IPCA Dynova team for this virtual meeting on topic role of Dapagliflozin in CV risk reduction and heart failure by Dr. Dharven Jain, sir. He is well-known speaker in medical fraternity across pan-India. Dr. Dharven Jain is the MD DM Cardiology, FNB Interventional Cardiology, FACC Fellow of American College of Cardiology, USA, FSCAI, FISC, FESC, FICC, FISC, FCSI. And he is Professor, Department of Cardiology, IMS, Bichu, Varanasi. And he is ex-consultant interventional cardiologist, MACE Heart and Vascular Institute, New Delhi. And ex-consultant cardiologist, Escort Heart Institute and Research Center, New Delhi. And he is awarded life member of Cardiology Society of India, Association of Physicians of India, Indian Society of Electrocardiography, Indian Academy of Electrocardiography, Indian Society of Cardiology, Indian Medical Association, Indian College of Cardiology, and American College of Cardiology, and MACE Healthcare Award 2009 for outstanding service at MACE Healthcare. So now, taking much more time, I hand over the session to Dr. Dharven Jain, sir. Over to you, sir.
Okay. Thanks for the nice introductory word, and thanks IPCA and the team for giving us opportunity to interact with our colleagues and seniors. We are discussing today a very important topic, that is role of Dapagliflozin SGLT2 inhibitor in CV risk reduction and heart failure. So it is a unique molecule, and irrespective of diabetic or non-diabetic, all heart failure patients are getting benefited. So we will discuss with the evidence available for this molecule, dapagliflozin. Friends, we all know that dapagliflozin is hitting two targets. One is the glycemic control, and another is the CV benefits. So we are having a benefit in diabetics for glycemic control and along with the CV benefits, and in non-diabetics it is giving all the CV benefits. So with DAPA, what are the cardiovascular benefits which we have? So we all know that this glycemia increases the risk of cardiovascular death. So high blood glucose increases the coronary heart disease. So it's related to the mean fasting blood glucose concentration, and as this increases, parallelly it is the coronary heart disease risk increases. Similarly, high blood glucose increases the vascular death also. So as the glucose rate increases, glucose level increases, the vascular death also increases. So this shows that the dysglycemia, if we can control indirectly, it will also control the cardiovascular disease. So friends, we all know that FDA has given some guidelines for the cardiovascular safety trials for antihyperglycemic medications. So whenever we introduce any new antihyperglycemic medications, we have to prove the cardiovascular safety. So there is a need of post-marketing trial generally will be necessary to definitely show that upper bound of two-sided 95% confidence interval for the estimated risk ratio should be less than 1.3. So this can be achieved by conducting a single trial, and that is adequately powered, or by combining the result from pre-marketing safety plus designed post-marketing safety trial, and this trial will be required for post-marketing safety trial. So DAPA and cardiovascular outcome in type 2 diabetes declared TIMI, it has shown the cardiovascular benefits of this molecule and published in Lancet. And the trial was with title of SGLT2 inhibitor for primary and as well as secondary prevention of cardiovascular and renal outcome in type 2 diabetes. It is a systemic review and meta-analysis of cardiovascular outcome trials. So declare cardiovascular outcome trial. In this, DAPA 10 mg was compared with the placebo for cardiovascular outcome in adult with diabetes and multiple CV risk factor or established cardiovascular disease. So it has two arms. One is for primary prevention, where the cardiovascular disease is not there, but diabetes. Patient is having a age of more than 55 in men and more than 60 in women, with multiple cardiovascular risk factors, at least one of the risk factors like dyslipidemia, hypertension, or current tobacco use, and without history of CV event at baseline. So these patients are for primary prevention arm. So 60% patients, 17,000 patients were in with diabetes were for primary prevention, where cardiovascular event has not occurred, but the risk factors are there. At least one of them is dyslipidemia, hypertension, and tobacco. Secondary prevention population is in which the already cardiovascular disease like ISD, ischemic CVA, or PAD, these already are there. So these are the proven patients, and here we want to prevent the secondary event. This is secondary prevention population. They are already cardiovascular disease in the form of CAD, stroke, or PAD is there. These 40% patients were there. Primary endpoints were set as a safety endpoint was composite of cardiovascular death, MI, and stroke, that is MACE. And two efficacy endpoints were there to see the cardiovascular benefits. That is a composite of hospitalization for heart failure and cardiovascular death and combined MACE. It has included global enrollment to 17,000 patients randomized at 882 sites and including 33 countries between 5 2013 to 6 2015, and primary endpoints were cardiovascular death or heart failure hospitalization, composite endpoint, and it has a superiority of 0.005 p value and 0.9% reduction. So similarly, MACE was also significantly reduced, and Dapagliflozin resulted in lower rate of cardiovascular death or hospitalization for heart failure, 4.9% versus 5.8%. So DAPA reduced the risk of hospitalization and hospitalization for heart failure, and it was 27% reduction in relative risk reduction of overall population with DAPA in comparison to placebo. So it met the primary safety endpoint versus placebo for composite of CV death, MI, and ischemic stroke, and P was very significant, non-inferiority. Then conclusion of declared TIMI 58. The type 2 diabetic patients at risk for atherosclerotic CVD, treatment with DAPA resulted in lower rate of CV death, heart failure, hospitalization for heart failure. It did not increase CV events. Reduction in HbA1c was 0.42%. DAPA heart failure. Role of dapagliflozin in heart failure. So types of heart failure: left-sided heart failure. EF is a measurement expressed as a percentage of how much blood the LV pumps out with each contraction, that is ejection fraction, and normally it is 50 to 70% blood is pumped out. So EF is usually 50 to 70%, and when it is reduced, so it is less than 40%, then it is called heart failure with reduced ejection fraction, and less than 40% of blood from LV is leaving the heart. In preserved ejection fraction, another group where the EF is more than 50%, so more than 50% of blood from LV leaves the heart. So here the ventricular walls are stiff and usually thickened. And we can classify New York Heart Rate System classification for heart failure, in which class 1, 2, 3, 4. We all know NYHA class, where in class 1 there is no symptoms. In class 2 there is mild symptoms. Class 3 marked limitation of activity, and class 4 is at rest. There is severe limitation. symptoms even at first. In class 5, they have given for no NYHE class listed or unable to determine. So, DAPA in patients with heart failure and reduced infection. Another trial is DAPA heart failure trial. So, it has a benefits in heart failure patients, diabetic or non-diabetic, all patients. So, DAPA in patients with heart failure and reduced infection, EF less than 40%, and class 2, 3, or 4 NYHE heart failure. So, phase 3 trial in heart failure patients with or without diabetes. In this, equal number of patients were there in DAPA versus placebo, and 18.2 months was the duration of the trial follow-up. DAPA reduced the cardiovascular death and hospitalization for heart failure. There was 26% reduction in risk of CV death or hospitalization for heart failure. So it was very early effect. You can see the curves were diverse very early. And the composite of CV death or hospitalization for heart failure was reduced 16.3% in DAPA versus 21% in placebo. So it's a 26% reduction in cardiovascular death or hospitalization for heart failure. Then these results are consistent in diabetic patients and non-diabetic heart failure patients. There is 27% reduction in non-diabetics, that is a reduction in risk of CV death or hospitalization for heart failure. And similar reduction was found in diabetics also, 25% reduction in risk of CV death or hospitalization for heart failure. So it's a significant reduction in both diabetic or non-diabetic heart failure patients. The benefits are there in all range. To conclude, trial has patients with much higher risk for hospitalization for heart failure and death, and even there is a 17% reduction in all-cause mortality. No other SGLT2 has indicated to reduce CV death in patients with heart failure with reduced infection, with or without diabetes. Only DAPA has proven in patients with diabetes and non-diabetes, both groups. So DAPA reduces the risk of heart failure hospitalization due to heart failure or death due to CVD in all patients, regardless of presence or absence of diabetes. That is the beauty of this molecule. So to take home this message, DAPA in patients who already had heart failure, it reduces the cardiovascular death, it reduces the hospitalization for heart failure, reduces the all-cause mortality, effect visible within 3 months, and similar benefits even in the elderly patients. Elderly receive highest benefits in this group. So thank you very much. Effect was similar in diabetic and non-diabetic.
Hello.
Hello.
Yes, sir.
Sir, Dr. Dharmen Jain is a big name in medical fraternity in Varanasi. So my request to audience, feel free to ask any query. So just wait for 1 or 2 minutes. I think not any question. So sir, thanks for your valuable insight for this session and given time from your busy schedule. Once again, thank you, sir. Sir, if you allowed, we would like to close the session.
Pardon?
Thank you so much for your time. So, sir, from here now, I'm ending this meeting. Thank you.
Okay, okay.
Have a nice day, sir.
Okay, thank you.